மேம் எப்ப ஆரம்பிக்க மேம்? வெயிட் பண்ணவா கொஞ்ச நேரம்? ஓகே மேம். இனி யாரும் வந்த மாதிரி தெரியல, வெயிட் பண்ணலாம் மேம். ஓகே மேம். ஓகே மேம். 2 minutes தான். ஓகே மேம். ஹாய் சாய் கிருஷ்ணா, வெரி குட் ஈவினிங். How did you find the questions yesterday? Yes. Am I audible? Thank you, Sai. So you completed your test anatomy, right? How were the questions? How did you feel? Okay. Lengthy. Okay. Case scenarios. Okay, the options and thing. Yeah. Yes, Sai, thanks for coming. We'll just wait for 1 more minute, okay? And then we'll start. So yes, you can try answering this question. Did you get it? You can write it in the chat box. What is A, B, C, D? Okay, guys, I'll start the session. Okay, yeah. So you know that neuroanatomy, like most of the questions are from neuroanatomy, head and neck, right? And they are image-based questions. Can you orient to which part of the brain is it? It's the base of the brain. Am I right? Yeah. It's the base of the brain. What is that ABCD you see here? This is called the interpeduncular fossa, right? So let's identify what are the structures here. Yeah. So what is this? That's the optic nerve, right? The optic nerve. This is the optic chiasma, right? This is the optic tract. Yeah. So by now you must be thorough with the lesions of visual pathway, right? Yes. So that question is important. So this is a very important image, okay? So where these structures in the visual pathway can be pointed and they can ask you the corresponding lesion of those areas. Now, what are these round structures that you see here in the base, in the region of the hypothalamus? Any idea what is it? These rounded elevations are the mammillary body, right? So these are the mammillary body. Recently, there was one question asked, I put that here. Where the, then this is the region of midbrain. Can you see? Yes, how to identify this is the midbrain? You see an opening here, right? Yes. What is this opening called? This is the cerebral aqueduct, right? Yes. And you can make out one dark structure here, right? So what is this? This one is the substantia nigra. Okay. Now what is the pointed area? We'll go back to this. Yeah. So A is mammillary body. B is the area that you see in front of the substantia nigra, which is nothing but the crus cerebri of midbrain. Okay, in the crus cerebri, in the middle part, we have the corticospinal fibers. So injury to the corticospinal fibers will lead to contralateral hemiplegia. Okay, see, as I told you, substantia nigra, its lesion will lead to Parkinsonism. And what is D? D is the tectum, which will have the superior colliculi, inferior colliculi, right? So any doubt in this? A, B, C, D markings, okay? Make sure you're thorough with the visual pathway. This was recently asked. Another view, right? The medial surface of the brain. And the one pointed out, that's the mammillary body. So the question was, which nucleus of the thalamus does it project into? Yes. So that forms the part of the Pappi circuit, right? Pappi circuit. And the fibers from here, they reach the anterior nucleus of thalamus, okay? So in this one image, there are so many things that you should definitely know, right? Yeah. And the lesions of which what will lead to. And one more thing, what are the conditions that will lead to contralateral hemiplegia? Yes. So this was also asked recently. Can you see this is the medulla, right? In the medulla, this region is the pyramid and olive. So in this image-based question, pyramid can be pointed out. Injury to the pyramid also will lead to contralateral hemiplegia. And in pons, this is pons, right? In the pons, the basilar part of the pons will again have the corticospinal fibers. Okay, so any syndrome involving the pons, the Millard-Gubler syndrome. If you have read, you will remember the Millard-Gubler syndrome. Lesion of that will also lead to contralateral hemiplegia, right? And in the midbrain, as we saw in the crus cerebri, the Weber syndrome, okay, involving the crus cerebri and the third nerve, that will also lead to contralateral hemiplegia. And the other cause, yeah, where does the corticospinal fibers come from? They come from the motor cortex, right? So any injury to the motor cortex, ischemic injury, or internal capsule, where the posterior limb has the corticospinal fibers. Injury to all these can lead to contralateral hemiplegia. So this one question is very important, where you should be able to identify the structure pointed, the lesion related to it, and the third thing, you should be able to list out what are the conditions why you get contralateral hemiplegia. Done? We'll move on to the second question. Yeah. This is again an important one, right, in upper limb. So what is this? Yeah, this is the extensor expansion, right? Yeah. So this is an again clinically important question. What is this extensor expansion? You have the metacarpal, and then you have the three phalanges, right? Proximal phalanx, middle phalanx, and distal phalanx. Where is this extensor expansion? It is exactly situated here over the metacarpophalangeal joint and triangular expansion. From this triangular expansion, the apex, no, it is split into three slips. One central slip that will insert into the base of the middle phalanx. Okay, so this is your proximal interphalangeal joint. And from the sides of the apex, you'll get two lateral slips that insert into the base of the distal phalanx. Okay, this is your distal interphalangeal joint. Now, into this extensor expansion, we will receive two muscles inserting. One will be your lumbrical, and the other is going to be the interossei. Yes. So what is the nerve that is going to cause extension of your elbow? Extension of the elbow, extension of the wrist joint, extension of the metacarpophalangeal joint. All that is under the influence of which nerve? Radial nerve. Okay. Yes, very good, Sai Krishna. Yes, the radial nerve. But the extension of your interphalangeal joint, proximal and distal interphalangeal joint, its extension is under the control of which nerve? The lumbricals and the interossei, which are innervated mainly by the ulnar nerve and median nerve. Okay, so this point you should remember. Now, what is happening in our condition? What is this here? So here, the patient is having difficulty in extending the distal interphalangeal joint. What is inserting into the distal phalanx? The lateral slips, right? So this is called as the mallet finger, right? And here what is happening? There is extension. The middle phalanx, how is it? Not able to extend the middle phalanx, okay? Your proximal interphalangeal joint is flexed and not extended. This is injury to the central slip. And this is called as the Botiner deformity. Am I right? The Botiner deformity. Here there is hyperextension of the proximal interphalangeal joint, hyperflexion of the distal interphalangeal joint, imbalance of the extensor expansion mechanism. This is called swan neck deformity. And this one is nothing but one additional information. Injury to the flexor digitorum profundus tendon of the ring finger, okay, which is going to be innervated by median nerve. This is called jersey finger. So what did the image show in our question? Yes, the central slip or the lateral slip? It's the central slip inserting into the base of the middle phalanx. So the answer is Botiner deformity. Got it right? Okay with the second question? Yes. So this is a frequently asked one. If there's injury to the lateral slip, that will lead to the jersey finger. Middle slip, Botiner deformity. Okay, no confusion? Yes. Yeah. So which among the following are derived from the second pharyngeal arch? Pharyngeal arch is an easy question, right? Yes. Can you tell me the nerve of these arches? You have given this mnemonic in the previous classes. Nerve of the first arch is mandibular nerve. Second arch, facial nerve. Third arch, glossopharyngeal nerve. Fifth arch, vagus branch, external laryngeal, and also your 11th nerve. And sixth arch, recurrent laryngeal nerve, isn't it? So this question is about the second arch. Yes? Yeah? So can you tell me what are the derivatives of the second arch? Yeah, you know, it's the 7th nerve. Any idea how many muscles it supplies? Easy way to remember. 7 muscles. Muscles of scalp, muscles of face, muscles of auricle, the muscle, superficial muscle of the neck platysma. Anything else you know? The SPB muscle, you have heard about it? Stylohyoid, posterior belly of digastric. And one more, can you add to it? Yes, what is that muscle within the ear supplied by the facial nerve? Come on. Stapedius. Yes. What is the very good, sir. What is the cartilage of the second arch called? Richard's cartilage, isn't it? What is the Richard's cartilage going to give rise to? Yes. All that starts with S, isn't it? What is it? Within the ear, stapes, and then we have the styloid process, stylohyoid ligament, the superior part of the body of hyoid, the smaller cornu of the hyoid, right? Yes. So you wouldn't have meant it tough, you would have got it right, I suppose. But this one they keep frequently asking, right? The pharyngeal pouches. What are the derivatives of the pharyngeal pouches? The first pharyngeal pouch will give rise to middle ear cavity, auditory tube, all that, right? The second one they keep asking frequently. What is the derivative of the second pharyngeal pouch? Palatine tonsil. And the third one, which is connected with the syndrome, yes, third one will give rise to TH and I. What is that? Thymus and, yes, inferior parathyroid. Okay, so what happens in DJOT syndrome? Both of them are not formed, leading to hypocalcemia and, yes, immunodeficiency. Okay, okay with this? Yeah, next one. This also they've asked recently over the previous year. Yeah, so what is it? We'll identify in the lung, right? This is a cadaveric specimen. What lung is it? Right lung or left lung? Yeah, you figured it out? That's the right lung. Yes, medial surface of the right lung, you're getting to see it. Okay, so this is the apex and that's the base. This is the hilum of the right lung. What is the arrangement of structures in the hilum of the right lung? Okay, easy. Always the inferior most structure is going to be the inferior pulmonary vein. Okay, inferior pulmonary vein will be the inferior most, right? And then here pulmonary vein is carrying oxygenated blood, right? So that's why I've shown it in this. And then you have the artery here, pulmonary artery, right? But what happens on the right side, the bronchus, okay, it will divide into two. One goes above the artery, one below the artery. So we call it as the eparterial bronchus. And the one below, we call it as the hyparterial bronchus. There are two pulmonary veins, right? So here anteriorly, we'll have the superior pulmonary vein. So the arrangement of structures in the hilum of the right lung will be eparterial bronchus, yeah, pulmonary artery, hyparterial bronchus, inferior pulmonary vein. In the left lung, it's going to be, yes, just the artery, bronchus, and the vein. Okay. Yeah. So here, which is the structure which lies intersegmental in a bronchopulmonary segment? How many bronchopulmonary segments are there in each lung? Yes? Come on. There are how many? 10 in the right. Very good. 10 in the right and 10 in the left, right? Okay, now while doing surgery, how do they demarcate these segments? What comes to lie between these segments? Huh? Yes? The pulmonary veins, okay, the pulmonary veins are intersegmental in position. Okay, so that can be a direct question or it can be image based. From the image, you can identify, right? This yellow color one is the nerve plexus. Okay, C is the pulmonary vein. Yeah, so that is what's shown here. If this is two segment, the pulmonary vein, they lie intersegmental in position, help you to identify it in the surgery, right? Okay, you must be thorough with all these segments, right, by now. Can you tell me which is segment 8? Can you name segment 8? Once it has been asked in your previous exams, it's also called as the cardiac segment. Any idea what is it? Yes, you told me there's 10, right? Yeah, you can hear it right. This is apical, posterior, anterior, lateral, and this is the medial, right? And the basal, lower lung, lower lobe, yeah, what happens? You have the apical basal, anterior basal. This is the medial basal, okay? The medial basal or the cardiac segment. Yeah. And then lateral basal and the posterior basal, okay? So you should be able to remember this. Yeah, medial basal segment. Hope you got it right. It was an easy question. Moving on to the next one. Yeah, this is frequently asked question in different format, right? Trendelenburg, about the gluteus muscles, about the gluteal nerves. Yeah, did you get it right? Recently, they put a picture of the bone, okay? And then they ask you through an indirect way. That's why I put this question. Yes. So the bone here is femur, right? What is B? Can you tell me what is B? B is the lesser trochanter. And this part, so this should be the greater trochanter, right? So what is the muscle inserting into lesser trochanter? Yes, the one inserting into lesser trochanter is the iliopsoas, right? Greater trochanter, the anterior surface of it. Yes, it receives the insertion of gluteus minimus. Okay. And the lateral surface or the part posterior that receives the insertion of gluteus medius. Now, what is D here? D is the gluteal tuberosity. What is this gluteal tuberosity going to receive? The lower fibers of, the 1/4 fibers of gluteus maximus. Okay, so you'll be learning in and out everything about Trendelenburg, gait, maximus, medius, minimus, and the gluteal nerves, but they can twist the question in any different format, right? So you should know their attachments because once gluteus maximus attachment was asked. Okay, so I will a little bit elaborate it here. Yeah. So what are the gluteal muscles you know? Gluteus maximus, gluteus medius, gluteus minimus. Okay, once they've asked the gluteal tuberosity, what muscle attaches and its actions. So what are the actions of gluteus maximus? Yes, come on, tell me. It is an extensor of the hip. It is a lateral rotator of the hip. The upper fibers also cause abduction. Okay. What are the actions of medius and minimus? Medius and minimus along with one more muscle. Yes, very good. Along with one more muscle. What is that muscle? Tensor fascia lata. Okay, these three together, what do they cause? They cause abduction. Very good. Abduction and medial rotation. Okay, and then they ask about the nerve supply. So superior gluteal nerve. Superior gluteal nerve that innervates these three muscles, medius, minimus, and tensor fascia lata. That is the inferior gluteal nerve that goes to innervate the gluteus maximus muscle. So what is Trendelenburg sign? When your, this is your right and left, right? So if your left foot is off the ground, there's a tendency for the left pelvis to sink, right? But the contraction of the muscles of the opposite side, they support it and prevent from sinking. So in case if the left pelvis sinks, what happens then? Yeah, there is injury to right superior gluteal nerve and paralysis of right side gluteus medius and minimus. Right? So however they twist it and ask, you should be able to write it. Okay, the muscles, the action, the nerve supply, the Trendelenburg sign, and the attachments. Okay, yeah, got it right? Yeah, this, and recently NEET-PG, they gave this image, right? Did you do that? So this is an image. What is this histological image? It's about the, you identify the glomerulus here. So these are the glomerulus. Did you see that? Yeah. So it's a slide of the kidney. Yeah. So in the cortex of the kidney, other than glomerulus, what are those? The PCT and DCT. What is the cellular appendage you expect to see in PCT? Yeah. Microvilli, which give it a striated appearance. Okay. So this is an indirect question asking you of the 4 options given, where do you get to see microvilli? Yes. Can you tell me? Which part do you get to see microvilli? So this is the cortex of the kidney. This is the medulla of the kidney. You can make out the Bowman's capsule. Yes, to show you the PCT and DCT. Very good, very good. Okay. So what are the other areas you get to see microvilli? Of course, in small intestine, duodenum, jejunum, ileum. Is that microvilli in large intestine? Yes or no? Large intestine. The absorptive cells, okay? Absorptive cells. There's no villi, but the absorptive cells will carry microvilli, okay? They can have a controversial option. Absorptive cells, okay? Yeah, that's going to have the microvilli. And any other place? PCT, gallbladder, right? What is present in stomach? Okay, nothing. You have the gastric pits. Fallopian tube, yeah, you get to see the cilia. Also in the respiratory epithelium. Vast difference, you get to see the stereocilia. Right? Okay, it's easy, right? Occlusion of the middle cerebral artery will cause infarction of which of the following areas? Yeah, sometimes instead of the image, you can get a list of the functional areas also, right? So what are the functional areas? You'll tell me the number as I mark it. So this is the central sulcus. Area 4 is the primary motor cortex, right? The primary motor cortex. And area 6 here, the premotor. What else do you get to see in the frontal lobe? Here 8 will be frontal eye field, right? Frontal eye field. This will be a prefrontal gyrus. Where's the motor speech area situated? Past triangularis, right? 45, 44, motor speech area. Broca's area is there, okay? And then here you'll have the auditory cortex, 41, 42. And then here visual cortex, 17. Superior power, here sensory cortex, 3, 1 and 2. Superior parietal lobule, 5, 7. Now, what are the three cerebral arteries you know? Anterior cerebral, middle cerebral, and posterior cerebral artery. Of the three, anterior and middle are branches of internal carotid. Posterior cerebral artery is a branch of basilar, isn't it? Basilar artery. What is their territory of distribution? Yes, we'll take a highlighter. So what is the anterior cerebral artery going to cover? The upper part up to the parieto-occipital sulcus. Am I right? Posterior cerebral artery, yeah, the inferior temporal gyrus on the supralateral surface. Sorry, we forgot the sensory speech area, right? Here you'll have the Wernicke speech area, the supramarginal gyrus and the angular gyrus, right? Sensory speech area. Now, yes, so the major part of your functional areas, they come under the distribution of middle cerebral artery, right? Okay, why have I put this question? Because over the previous years, did you go through the paper? They have asked, what did they ask? They have asked the blood supply of fornix. They have asked the blood supply of genu. They can ask you the blood supply of paracentral lobule, right? The paracentral lobule is over here, where the lower limbs, the perianal, genitourinary areas are situated there, right? So remember, the genu, yes, that is also a fornix, all will be supplied by anterior cerebral artery. Paracentral lobule, anterior cerebral artery. Fine. So functional area, which area supplied by which artery? Cerebral artery, important. Fornix is striate branches of anterior cerebral artery. Right? Yeah, I'll just read the last line alone. CT brain showed features suggestive of ischemia in the territory of middle cerebral artery. Okay, so which area will not show ischemic changes? The primary motor cortex, the motor speech area, primary sensory cortex, everything is going to be by middle cerebral artery. Okay, visual cortex is by posterior cerebral artery, which will not show ischemic changes. Huh? Yes, it's easy. So what were the correct statements about the pointed structure? What is the pointed structure here? The pointed structure is, come on, side. That's the external oblique upper neurosis, isn't it? So what are the contributions by it? Its lower border, it interns to form the inguinal ligament. What is its other name? Paupart's ligament, right? What are the three extensions of the inguinal ligament? Yes, it has the lacunar ligament. What is its other name? The Gimbernard's ligament. Yes, and it also gives rise to the pectineal ligament of Cooper. One more, the reflected part of inguinal ligament, right? What are the other contributions? What is this ring here? Recently, NEET-PG, they asked, right? That's the superficial inguinal ring. What fascia comes out from the margin of superficial inguinal ring? External spermatic fascia, right? And then what is its contribution to the inguinal canal, external oblique aponeurosis? It forms the floor plus the anterior wall, right? And what is its contribution to the rectus sheath? It forms the anterior wall of the rectus sheath. Now, what is this lumbar triangle of Pettit? Okay. Yeah, so this is the lumbar triangle of Pettit, anteriorly by the external oblique, posteriorly by the latissimus dorsi, in the floor iliac crest. I'm sorry, yeah, the base is formed by the iliac crest, and in the floor you have the internal oblique fleshy fibers. Okay, so what were the statements that were correct? Yeah, anterior wall, floor, Cooper's ligament, deep inguinal ring, right? Yeah. Sorry, not this one. Okay. Now, what is this conjoint tendon? Conjoint tendon is formed by 1/3 contribution from internal oblique and 2/3 by transverse abdominis. Okay. Lower border is going to form the Paupart's ligament. Internal spermatic fascia, where does it come from? From the margins of deep inguinal ring. And the deep inguinal ring, yes, it's the opening where? In the fascia transversalis. Okay. Yeah, it presents the superficial and not the deep inguinal ring. Okay, about external oblique aponeurosis, the same thing can be asked for internal oblique and the fascia transversalis also. So one question from general anatomy every year, like related to joints, what type of joint was it? Yeah, so did you get it right? This one? Yeah. So what are the joints that you see here? Between the costal cartilage and the rib. Yeah, there shouldn't be any movement, right? So it's a primary cartilaginous joint, synchondrosis. Similarly, the first rib, the attachment between the first rib and the cartilage also. Okay, here. Yeah, this joint here between the first costal cartilage and the sternum. It is fixed, right? Not much movement there. So again, this is a primary cartilaginous joint, right? And all the midline joints in the body, the manubriosternal, the xiphisternal, and the intervertebral joints, all of them are going to be secondary cartilaginous joint, right? Yeah. So here, so A is again primary cartilaginous joint. B, I told you primary cartilaginous joint. C is secondary symphysis. D is again symphysis, but in the option we didn't have B and D, right? I mean, yeah, C and D. Then what is E? That was one previously asked, okay? The joint between the rib and the vertebra, whether it is costovertebral or costotransverse, it's going to be plain synovial, right? F, the joint between the cartilages, as you see here, they are plain synovial, except between the 9th and 10th. The last one is fibrous. Now, can we quickly revise, okay, what you know? What are the ball and socket joints in the human body? Can you tell me? Easy? Yeah? You'll tell me shoulder joint. You'll tell me hip joint. Then, within the ear, between the ossicles, you get any ball and socket joint? Between incus and stapes, right? What are the pivot joints in the human body? Pivot, talocalcaneal. Yeah, very good. Talocalcaneal. Yeah. What are the pivot joints in the human body? The superior, this was asked once, right? Superior and inferior radio-ulnar joint. Yes, anything else? One more. The joints of no. What are they called? What are the joints of no? Median atlantoaxial joint between the dens, remember? Yeah, median atlantoaxial joint. Okay. Yeah. What are the saddle joints in the human body? Saddle, right? Anything in the upper limb? The joint of the thumb, right? The first carpometacarpal joint. First carpometacarpal joint. Then, yeah, as you told in the lower limb, the calcaneocuboid joint, and in the ossicle of the ear between malleus and incus. Okay, these are the saddle synovial joints, right? Ellipsoid. Do you want to tell what are the ellipsoid synovial joint? Wrist joint, metacarpophalangeal joint. Yes, and the joints of yes. What are the joints of yes? The atlanto-occipital joint, right? The atlanto-occipital joint. Very good. Those are the joints of yes. They are also ellipsoid joint. Hinge joint, hinge, elbow, interphalangeal joint, knee joint. Plain synovial, you know, right? The acromioclavicular joint, the acromioclavicular, the intercarpal, the joint between the rib and the vertebra, all those are plain synovial joint, right? Yeah, yes, there's an image-based question in this cubital fossa frequently, right? So you can identify the medial and the lateral here. This protruding part is the medial epicondyle. Here you'll have the lateral epicondyle and you know MBBR, right? So what is the pointed structure here? The pointed structure here is median nerve, right? Yep. And the one next to it is the brachial artery. What is the level of termination of the brachial artery? Neck of radius, okay? And next to it, what you see? The bicipital upper neurosis. Do you know where the biceps tendon inserts into? The tendon goes for insertion into radial tuberosity. And this structure also can be pointed out frequently, right? On the other end of the cubital fossa. What is that? That's the radial nerve. Okay, now Sai is going to tell me what happens if there's injury to the radial nerve. Yes. Wrist drop. Very good, right? Now, what happens when there's injury to the median nerve, the one that's pointed out, okay? So, yeah. So, what is the answer for this? Yes. So, we can identify here. Yeah, very good. So, what are the muscles supplied by the median nerve? Yeah, the loaf muscles you must be hearing about. The first and the second lumbrical, opponent's pollicis, the thenar muscles, right? Abductor pollicis, yeah, flexor pollicis brevis, right? And in the fora, pronator teres, yeah, flexor carpi radialis, palmaris longus, flexor digitorum superficialis, anterior interosseous nerve, it goes to supply, flexor pollicis longus, flexor digitorum profundus for the which fingers? The middle finger and the index finger, right? Middle finger and index finger and pronator quadratus, right? So during our INICET rapid revision, we have seen in detail about median nerve and the test for that, right? Yeah. So what is this called? The hand of benediction, enabled to flex the distal phalanx. Again, Oshner's clasping test, inability to flex the distal phalanx. Pen test, right? What is the muscle tested here? Come on. The pen test is to test which muscle? Yeah. Abductor. No. Okay. So what is abduction actually? So your thumb is in the same plane with the other digits. You call it as adduction, right? If you take it towards the ceiling, if you lift it up, that you call it as abduction. Across and you touch it, that will be flexion. This is extension. So abduction, the action tested for the pen test is abduction and the muscle tested is abductor pollicis brevis, which is innervated by median nerve. Okay. Why not abductor pollicis longus? Abductor pollicis longus is going to be innervated by radial nerve, and that inserts into the base of the first metacarpal. It doesn't come to the phalanx of the thumb. Okay, so please make sure pen test is for medial nerve, abductor pollicis brevis. And again, this is your eighth thumb. This is due to paralysis of opponent's pollicis. This is to show you median clawing, because the first and second lumbrical, yeah, which are supposed to cause extension of the interphalangeal joint, if they are paralyzed, will go for clawing, right? The first and the second lumbrical. And this you must be knowing, right? Anterior interosseous nerve syndrome, where the patient can't flex the distal phalanx of the thumb and the index finger because it supplies FPL and FDP, right? What is the syndrome related to it? Kevin, yeah, Kilon-Nevin syndrome. Okay. And this one, yeah, good. Huh. So what is this? Just wanted to put a cadaveric image. The structure pointed out is your superior thyroid artery, and the nerve that accompanies it will be the external laryngeal nerve, which is going to supply the cricothyroid muscle. What is the action of cricothyroid? It's a tensor of the vocal cord. So injury to that will result in, yes, weakness of voice, right? You want to stretch it, you're not able to stretch it, right? And when you shout, the voice will be weak. You can't call someone who's very far away. Weakness of voice. What about the other laryngeal nerve, you know? Internal laryngeal nerve is purely sensory. It is going to supply the mucosa of the larynx above the level of vocal cord. Mucosa above the vocal cord, right? Recurrent laryngeal nerve is a mixed nerve, right? So it supplies the mucosa below the vocal cord and also motor to all muscles of larynx except cricothyroid. So what will happen if external laryngeal nerve is injured? Weak voice. Internal laryngeal nerve is injured, it is sensory, right? It will lead to aspiration. You can't cough out, right? Recurrent laryngeal nerve will lead to aspiration, hoarseness of voice. Why dyspnea? Why is there dyspnea, difficulty in breathing in recurrent laryngeal nerve palsy? This recurrent laryngeal nerve is going to supply, which is the safety muscle of larynx. The safety muscle of larynx is posterior cricoarytenoid. What is this posterior cricoarytenoid going to do? Abduction of the vocal cord, right? So if the abductors are paralyzed, the cords, they lie in the paramedian position, making difficulty in breathing. Okay. So the answer here is, yeah. Now, can you quickly identify? Yeah, this is the image. You can see the superior thyroid artery here. You can see the external laryngeal nerve here. Can you tell me what is this nerve here? Running in the tracheoesophageal groove. That's the recurrent laryngeal nerve, right? That's the recurrent laryngeal nerve. And then, yeah, this one, this is the vagus. Here you see the left vagus. This is the right vagus. So this is the left recurrent laryngeal nerve, which is winding around the arch of aorta. And this is the right recurrent laryngeal nerve, which is winding around which artery? The first part of subclavian artery. One more nerve I would like to show you in this image. Can you tell me what nerve is this? This is the, yes, phrenic nerve, which runs on the anterior surface of scalenus anterior muscle. Okay. External laryngeal, recurrent laryngeal, vagus, and the phrenic nerve. All that you can make out in this diagram. Same thing I'll show you here. So the clue to identify recurrent laryngeal nerve is going to run in the tracheoesophageal groove, right? And here again, you can see this is the phrenic nerve, right? On the surface of scalenus anterior muscle. And here the carotid sheath, like you see IJV, the common carotid artery. So this is going to be vagus. And you can see the ganglia here. This is cervical part of sympathetic trunk, right? Sorry, where is that? One second. Here. This is the right recurrent laryngeal nerve, which I told you is going to wind around the first part of subclavian artery. Okay. This was asked in the previous years. Okay. Now, can you tell me what is ABCD? Where is A? So this is your trachea. I'll take a different color. This is trachea. This is esophagus. So what is A? A is going to be the recurrent laryngeal nerve, right? Very good. Then what is B? B you see within the carotid sheath. So that is going to be vagus nerve, right? And C, what is C? C you see behind the carotid sheath. So that's going to be sympathetic trunk. D. Any idea what is D? D. I'll take you back to a previous image to let you know what is D. So this is scalenus anterior, this is scalenus medius. What are these yellow bunches emerging between scalenus anterior and medius? That's the trunks of the brachial plexus. So this is the landmark where you get to see supraclavicular block of brachial plexus. You can see the trunks emerging between scalenus anterior and medius, right? So either scalenus anterior, either scalenus medius, and what you see here will not be nothing but the trunks of the brachial plexus. Okay. Now, where is phrenic nerve? Phrenic nerve, இவ்வளவு நேரம் எல்லா இமேஜ்லயும் பார்த்தோம்ல. இங்க எங்க phrenic nerve இருக்கு? So this is scalenus anterior. Can you make out this nerve anterior to scalenus anterior? This will be the phrenic nerve, right? So this is the trunk of the brachial plexus. This is phrenic nerve, cervical part of sympathetic trunk, vagus, recurrent laryngeal nerve. Right? So, end the image kuduthalu, you should be able to figure it out. Okay, done? Yeah. Now, this is easy, right? So, vessel is seen. Normally, what will be the layers of the vessel? You'll get to see a lumen, then you'll see tunica intima, tunica media, tunica adventitia, right? So, in an artery, remember in an artery, the lumen is going to be compact. Whereas in a vein, the lumen is going to be collapsed, okay? If it's a large one, you won't be able to make out the entire thing here. And tunica media is the major factor, tunica media and adventitia. In the artery, tunica media is going to be of larger size. Where in the vein, tunica media is going to be small, okay? If it is a larger artery, tunica media will be full of elastic fibers. You can't make out the internal, external elastic lamina. Medium size artery will have smooth muscle fibers. Okay. Whereas in a large vein, please note it down, the tunica adventitia is large, as you see here. This entire thing is tunica adventitia. And you can see a lot of bundles of smooth muscle fibers. So the image seen here is large vein. Okay. A large vein. And you can pick out the choice from here. IVC. If it's abdominal aorta, it's going to be elastic artery. Superior mesenteric artery na tunica media la nariya smooth muscle fibers irukum. Right? Easy. Lacrimal gland. Yes, we'll start the pathway. So where is the nucleus? The lacrimatory nucleus, which is in pons. Yeah, fibers are going to pass through seventh nerve. Its sensory component, nervus intermedius. Now, what is there in the seventh nerve? Geniculate ganglion, right? What is going to come from the geniculate ganglion? Greater petrosal nerve. Now, this greater petrosal nerve is going to be joined by deep petrosal nerve. Deep petrosal nerve எங்க இருந்து வருது? Internal carotid artery சுத்தி இருக்கிற sympathetic plexus. Now, both are going to unite and form the nerve of pterygoid canal. Okay, and this is going to come and end in which ganglia? The pterygopalatine ganglia. Pterygopalatine fossa la irukra pterygopalatine ganglia. And this will be connected to maxillary nerve, isn't it? Maxillary nerve kuda idu vandu topographic la connected ah irukum. Adoda zygomaticotemporal branch and then lacrimal nerve. Do you know the lacrimal nerve is a branch of which nerve? Lacrimal nerve edoda branch theriyuma? Trigeminal oda ophthalmic division oda branch, right? So seventh nerve, maxillary nerve, ophthalmic nerve, all these are involved in this lacrimal gland secretomotor pathway. Okay, so if you know this, it would have been easier for you to figure it out, right? Yeah. Now they frequently ask this question: What are the cranial nerves which have parasympathetic component? Sai solrengla. Parasympathetic component. What are the cranial nerves which have parasympathetic component? Yes. 3, 7, 9, 10. Right? So third nerve from the Edinger-Westphal nucleus. Yes, the fibers are going to pass through nerve to inferior oblique. What ganglia is related to it? Ciliary ganglia. What are the postganglionic fibers called? Short ciliary nerves, right? And what do they innervate? In the ganglia and the fibers, they are going to innervate which muscles? Yes, ciliaris and sphincter pupillae. So third nerve lesion, yes, third nerve lesion, what will happen? Loss of accommodation and dilated pupil, isn't it? Two features because of the parasympathetic component. Seventh nerve, இப்பதான் பார்த்தோம், lacrimatory nucleus is for the lacrimal gland. What is the other two glands supplied by seventh nerve? The superior salivatory nucleus. Okay, chorda tympani valiya in the fibers போகும். This chorda tympani will join the lingual nerve, right? And what is the ganglia related to it? Submandibular ganglia. Fibers are going to supply submandibular and sublingual salivary gland. 3, 7, 9, 10. Ninth nerve, another inferior salivatory nucleus. It will pass through the ninth nerve, the tympanic branch, lesser petrosal nerve. What is the ganglia related here? Otic ganglia. Very good, very good. Okay, and the fibers are going to pass through auriculotemporal nerve, right? And to supply the parotid gland. So, it's Frey syndrome, right? And 10th nerve, you know, it's the vagus, parasympathetic to heart, lung, GIT, blah, blah. Okay. So, remember 3, 7, 9, 10. Okay. Yeah. Got it right? Yeah. So, what was this? Pudendal nerve block, right? So, yeah. So this pudendal nerve, it's a very straightforward question. There's nothing complicated at all. It is a somatic nerve coming from sacral plexus. Root value in S2, S2, S3, S4, right? Pudendal nerve. In the pudendal nerve is somatic. What are the things it's going to supply? Okay. But yeah, I'll tell you. So either another, you can see the anal canal here, right? Inga pudendal canal irukkudu. So this pudendal nerve is here. Okay, it's going to divide. It's going to give an inferior rectal nerve. Inferior rectal nerve. It's going to traverse the ischioanal fossa and it's going to supply what? This is the one I'll put. That's the external anal sphincter. Okay, this question, like this content, there's a high yield point of it. And then it will supply the perianal skin. It supplies the perianal skin. And then it supplies the lower part of the anal canal below the pectinate line. Okay, above the pectinate line, you know, the anal canal and the rectum is going to be supplied by the autonomic nerves, the sympathetics and parasympathetics. Okay, yeah. And then, so that's about the first option, these three things. Yeah. What about the perineal body? So this pudendal nerve will give a branch, the perineal branch, that will supply the muscles of both superficial and deep perineal pouch. What are the muscles in the superficial perineal pouch? Three muscles, right? The ischiocavernosus, bulbospongiosus, and superficial transverse perineum. Deep perineal pouch la rendu muscle irukku, sphincter urethra and the deep transverse perineum. These will contribute to the perineal body along with the external anal sphincter and levator ani. So, adavum, okay, vulva is your lower part of the vagina, that is also supplied. What is urogenital diaphragm? Urogenital diaphragm, the inferior fascia of the urogenital diaphragm or the perineal membrane that's going to cover the deep muscles in the deep perineal pouch. That is also going to be supplied by the pudendal nerve. As I told you, rectum, right? Rectum is going to be supplied by the autonomic nerve plexus, not by the pudendal nerve. So the sensation is going to be preserved. It's not going to be affected. And this was a recently asked question. Is this lama, right? So as I told you, A is internal anal sphincter, B external anal sphincter, C is levator ani, pubococcygeus, iliococcygeus. Yeah. And then D another. D the obturator internus muscle. Okay. Yeah. So we got the answer. Easy. What is the muscle pointed? The muscle pointed here is going towards which digit? Yeah. So you see the thumb, right? This is the thumb. So this will be your thenar muscles. This will be the hypothenar muscles. Okay. Thenar muscles, the abductors are always in the border. Okay. Abductors, you have to, of course, abduction. You have to move it toward like away from the midline, right? So the abductors in the border. This is the abductor pollicis brevis. This is the abductor digiti minimi. உள்ளார இருக்கிறது flexor pollicis brevis. This will be flexor digiti minimi. What is the muscle mark? You can see it going towards the thumb, right? The muscle marked here is adductor pollicis. Okay, very, very important one. The adductor pollicis. And its nerve supply is going to come from the deep branch of ulnar nerve. Right? So, yeah. Median nerve muscles, we already saw what it supplies. Superficial branch of ulnar nerve is cutaneous and it supplies only one more muscle, palmaris brevis. Okay, the deep branch of ulnar nerve, it supplies the hypothenar muscle. As we saw now, it supplies the adductor pollicis. It supplies the lumbricals. Which lumbricals? The third and the fourth and all the interossei. Right? Palmar interossei, dorsal interossei, everything it is going to supply, right? Okay. So here this picture is to show you the lumbrical. Previous year they have pointed out the lumbrical. You can make out the first lumbrical, the second, the third, and the fourth. Remember, first and second when the unipennate by the median nerve. Third and fourth bipennate by the ulnar nerve. And all of them are going to insert into the extensor expansion. And what is the action? Yes, metacarpophalangeal joint flexion, right? And yeah, interphalangeal joint, both proximal and distal interphalangeal joint extension. Its paralysis will lead to clawing, okay? And these lumbricals are the distal wing tendons of the extensor expansion. Whereas the interossei are called they insert proximally, they are called as the proximal wing tendons. Okay, so all this you must be knowing. Previous year question, I put it or not. They just pointed out the extensor expansion of the middle finger and they asked you which tendon doesn't contribute to it. Okay, this middle finger is important, right? Yeah. So which of the tendon doesn't contribute it? Middle finger one, it lies in the midline. Okay, what is the action of palmar interossei? Palmar interossei, we have remember, right? Pad, adduction. They cause adduction. What is the action of dorsal interossei? Dab, remember they cause abduction. So the middle finger, note it down. Yes, it already lies in the midline. It need not be adducted. Okay, so the middle finger has no palmar interossei. Okay, they have asked it once before. Can you see here? These are the dorsal interossei. It receives two dorsal interossei because you can move the middle finger on either way, right? So it receives two dorsal interossei and two dorsal interossei. Okay, so yeah, remember that. Okay. This was the question. The market tendon is not contributed by the palmar interossei, the middle finger, right? Yeah, this we have seen. We'll move on to the next one. Yeah, every time they ask about this pharyngeal artery derivatives, you got it right, isn't it? So yes, what is the remnant of the first arch? Yeah, maxillary artery. Recently they've asked it, right? And the second one, hyoid and scapedial artery, isn't it? What does the third arch going to give rise to? The third arch, as you see here, right? This one. Yeah, what is that? The third arch is going to give rise to the common carotid artery. That's going to divide into external carotid and internal carotid. The most important here is the fourth arch and the sixth arch. Right. What happens to the fourth arch on the right side along with the seventh cervical intersegmental artery? What is it going to give rise to? It's going to give rise to the right subclavian artery. Left side enna podu? It's going to give rise to a part of the arch of aorta. Very good. Okay. Part of the arch of aorta. Very good. Very good. Okay. Now coming to the next important one, sixth arch artery. Very, very important. In the sixth arch artery is going to give rise to pulmonary artery, both on the right and the left. But what is the difference here? So this part, what is it called? It's called the ductus arteriosus, which is not present on the right side, isn't it? In the left side, it will later form the ligamentum arteriosum. Okay, so that they have asked in previous year questions, you should know the derivatives. Yeah, and they've asked why does the course differ on the right and the left side for the recurrent laryngeal nerve? Yeah, because on the right side, what happens? The ductus arteriosus part is missing. Okay, so the recurrent laryngeal nerve, the right recurrent laryngeal nerve, as we saw in the previous image-based question, it goes up to wind around the first part of subclavian artery. In the left sixth arch artery or ductus arteriosus is the remnant irukka pogudhu. So that will wind around it. The left recurrent laryngeal nerve is going to wind around the arch of aorta to the left of ligamentum arteriosum. It's given off in the thorax. That is why the course differs on right and left. Longer course on the left. Okay. Yeah. Got it right? This was another easy one. So chorea. You should know what are the part affected in chorea, right? So chorea, the lesion involves the caudate nucleus and putamen. Okay. So in this image-based question, you should be able to identify whatever label. Okay. So here, what is this? This is the corpus callosum, right? The genu of the corpus callosum. So this will be septum pellucidum, which is separating both the half, the lateral ventricle. This under surface of the corpus callosum, septum pellucidum keela enna connect panadhu fornix. Okay. This is the midline. On either side of the midline, you get to see the thalamus. This is again corpus callosum, the splenium of the corpus callosum. This will be the anterior horn and the posterior horn of the lateral ventricle. Anterior horn are probably the body of the lateral ventricle. Now, what is this? This V-shaped thing. That's the internal capsule, right? The internal capsule. Now, you can make out the lentiform nucleus here. The outer part is the putamen and the inner part is the globus pallidum, right? Okay. This will be the claustrum. Claustrum. Inner to the claustrum is the external capsule. Outer to it is the extreme capsule. This will be the insular cortex. Okay. So here I will tell it again. Yeah, no doubt in this, right? So here, this is the caudate nucleus. Here also you can see the tail of the caudate nucleus. That is the head of the caudate nucleus. This is tail of the caudate nucleus. So in chorea, what is involved? Yes, A and D. D is putamen. Now tell me if in case you have a sign of intentional tremor, what are the other movement disorders? Where is the lesion? Intentional tremor அப்படிங்கிற ஒரு வார்த்தை case scenario பாத்தீங்கன்னா, where is the lesion? It involves the which part of the brain? Cerebellum, right? Resting tremor, where do you find? Resting tremor is seen in Parkinsonism, right? Yeah, very good. So chorea, you know, it involves the caudate nucleus and putamen. What about hemibalismus? That involves the trunk, right? Yeah, the lesion is in the subthalamic nucleus. So these disorders and the lesion, very good side. Good. Okay. Yeah, this one, I'll just highlight the important thing. Fracture of the lower fibula, pain over most of the dorsum of the foot, difficulty in turning the sole outwards, which means that eversion. So what are the muscles causing eversion? Peroneus, longus, peroneus brevis, peroneus tertius. But the nerve supplied to these two is superficial peroneal nerve, and this one is deep peroneal nerve. Why? Peroneus tertius is seen in the anterior compartment of the leg. Longus and brevis in the lateral compartment of the leg. Okay. So another thing, the superficial peroneal nerve, if this is the leg, okay, at the junction of the middle two-third and lower third only, it pierces the deep fascia to become cutaneous. At this area, it is more liable for injury. Okay, junction of middle and lower part. And yeah, so this is your peroneus tertius in the anterior compartment. This is longus and brevis. Okay. The nerve of the anterior compartment, all the muscles of the anterior compartment is supplied by deep peroneal nerve. Posterior compartment, we have the tibial nerve. Lateral compartment, we have the superficial peroneal nerve, right? Okay. This is very, very important. So what is the cutaneous innervation to the dorsum of the foot? Once they've asked this, what is this area? Yes, up to the first metatarsophalangeal joint. This is the saphenous nerve. So you know how the question was framed? It accompanies the great saphenous vein. So while doing a procedure on the great saphenous vein, the accompanying structure was involved. So where was the loss of sensation over the foot? Okay. And this one here, this is the area, the first interdigital cleft that's supplied by deep peroneal nerve. So, you know, the deep peroneal nerve, injury to the deep peroneal nerve will result in what? Yeah, important question, foot drop. So that your question can be like, in the foot drop, where is the loss of sensation, right? The deep peroneal nerve. And this one, this blue area on the lateral border, that's the sural nerve. It's again a branch of tibial nerve, right? And the most of the dorsum of the foot, entire thing is going to be supplied by superficial peroneal nerve. Got it right? So lateral compartment of the leg. Done. Okay. The blood supply to the part of the conducting system that traverses the marked structure. So what is this marked structure? This marked structure is the moderator band. It is also called the septomarginal trabeculae. Now, what is going to traverse this? The structure that traverses this is, yes, come on, Sai. Yeah, which part of the conducting system is going to travel it? Yes, from the bundle office, we have the right bundle branch, okay? That is going to traverse the moderator band, right? Okay, and reach here. Now, the blood supply to this, yeah, where does the blood supply come from? So, what are the parts of the conducting system? We have the SA node. Sorry, 1 second. Yeah. SA node is there, AV node, bundle of his. We have the right bundle branch and the left bundle branch. Okay. And we have the two arteries, right coronary artery, left coronary artery. So the SA node is predominantly supplied by right coronary artery. AV node is also predominantly supplied by right coronary artery. But at times, in few people, they can be supplied from the left coronary also. Okay. Now the bundle of his right bundle branch and left bundle branch, they lie in the anterior part of the interventricular septum. That is going to be mainly supplied by, yes, the left coronary. Okay. All these because of its location in the anterosuperior part of the interventricular septum. Now, this bundle of his and left bundle branch can be supplied by right coronary. But always remember, the right bundle branch is going to be supplied only by left coronary artery because of its positional placement, right? Okay. Yeah. Now, previously they've asked about they've marked one area, like this is the question. Yeah. So they've marked one part of the heart and they asked which are the arterial supply to it. So we'll just go through it. Right coronary artery supplies right atrium, Right ventricle. Does it supply any part of the left ventricle? Of course, right? This part of the left ventricle that is close to the postero-interventricular septum is supplied by the right coronary. And as you told, SA node, AV node, yeah, and the postero-inferior 1/3 of the interventricular septum is supplied by right coronary. Okay, yeah. And the left coronary artery that supplies left atrium, left ventricle. Does it supply any part of the right ventricle? Of course, this area closer to the anterior interventricular groove is supplied by left coronary, left anterior descending artery. Then as we saw now, it supplies the bundle of his, the right bundle branch, the left bundle branch, the antero-superior 2/3 of the interventricular septum. Right? Okay. So what was the question? They marked which part? They marked the right ventricle. Okay. These terms alone. The marginal artery, okay, which runs along the inferior border of the heart. That's again a branch of right coronary artery. Diagonal arteries, okay, which come from the LAD. They are branches of the left anterior descending or the anterior interventricular artery. And there's one more, right? What is that? Obtuse marginal. Yeah, the obtuse marginal branches are coming from the left circumflux artery. Right? So these other terms also you must be familiar with. Okay, so we're done with this. Yeah, you got it right. So this is again a very important question. They keep asking about the pterion, right? So the market structure is pterion. Now, over the previous years, what were the questions that were asked about pterion? What are the bones which contribute to the pterion? Yeah. So this is the frontal bone. This is the parietal bone. The temporal bone. What is that shown in green color? Sorry, not green color. This one. This is the greater wing of sphenoid. Okay. So there are 4 bones which meet here. Frontal, parietal, temporal, and greater wing of sphenoid. Done. Now, what is the artery that lies beneath it? Yes, the anterior division of middle meningeal artery. Now, this middle meningeal, can you tell me, Sai? It's coming from which artery? Maxillary artery. To be more specific, the first part of maxillary artery. And then I ask, what is the fontanel corresponding to it? The anterolateral fontanel or the sphenoidal fontanel, right? It corresponds to the position of pterion. Now, fracture of this middle pterion and rupture of middle meningeal artery will lead to extradural hemorrhage. Okay. And then, yeah, what are the other things that lies underneath the pterion? You have any idea? That's the Broca's, the motor speech area that lies underneath the pterion. And then the lateral sulcus of the brain, that is also related to pterion. And once they ask like which bone, okay, which lies deep to pterion, 4 options were given. The lesser wing of sphenoid. I'll put an image to show that, okay. The lesser wing of the sphenoid will also correspond to pterion on the inner aspect, right? So there are many questions related to pterion. Each year they ask repeatedly. Now, can you see here? These impressions here on the skull, these are the impressions produced by the middle meningeal vessel. Okay. Now, this part which I'm going to show in green here, yeah, this one, you can see there or a highlighter. This is the lesser wing of sphenoid, right? So one year they asked this also once, the lesser wing of sphenoid. On the inner aspect, it reaches the pterion, right? Like this picture is better, yeah. So you can identify the foramens here. Which color will be better? This one here, I'll take a yellow. Yeah. So this one is the foramen rotundum. Or Vasha eppadi ketirundanga theriyuma? They put the picture of sphenoid. Can you identify which is foramen rotundum here? This one, okay. This one is the foramen rotundum, which opens into the pterygopalatine fossa. This is the pterygoid canal. In the lacrimal gland secretomotor pathway, we saw about nerve of pterygoid canal, right? So this is the pterygoid canal. What bone is this? This is the sphenoid bone. Okay, so once they put the sphenoid bone and they pointed towards the foramen rotundum, what is going to pass through foramen rotundum? Foramen rotundum, maxillary nerve, right? And then foramen ovale and spinosum, you can identify here. Foramen ovale, yes, you know about the male structures, right? Mandibular nerve, accessory meningeal artery, lesser petrosal nerve, and the emissary vein. This is the foramen spinosum. We were talking in related to pterion, right? The middle meningeal artery and nervous spinosum. And the other one they keep frequently asking is this one. Yeah. What is this foramen? This is the jugular foramen. What are the cranial nerves related to jugular foramen? 9, 10, 11. What is the syndrome related to jugular foramen? Yes, they keep asking about that. Very good. Wernicke, okay? Wernicke syndrome. Yeah, okay? Very good. And once they asked what, they gave like which foramen is located between the three bones. Okay, what were the bones, They were telling about greater wing of sphenoid and then temporal bone and occipital bone. The foramen which is located between these three bones. Yeah, the foramen lacerum. Can you see here this part? This is the foramen lacerum. The foramen lacerum. So what you see here in this yellow color, yeah, that is the sphenoid bone. The pink color here is the temporal bone, and the purple color that you see here, this is the occiput bone. This is foramen lacerum. And to show you, yeah, I think I put another image also. Here, where is foramen lacerum? Here in the inner aspect of the skull, this one, on either side of the body of the sphenoid. Okay, so foramen of skull is another high yield topic. They keep asking in different aspects, right? The histological image is not here. Okay, yeah, the true statement about the terminal bronchiole. Yes, did you get it right? Yeah. What is a true statement? Because once they've asked about the respiratory epithelium. What is a respiratory epithelium? It is pseudostratified, ciliated, columnar epithelium, right? You can make out the cilia here. A is cilia. What is B here? B is the goblet cells, right? C is the nuclei of the epithelial cell. And D is the basement membrane. It's not the lamina propria. So what are the things that you're supposed to know about the respiratory epithelium? This is the picture of trachea. Yeah. What cartilage is this? Another important high yield topic, right? The cartilages. So the cartilage that you find in trachea is the hyaline cartilage, right? Hyaline cartilage, right? Yeah, so you have a homogeneous matrix, that isogenous cellness, everything that, right? Now, trachea is going to further divide into bronchus, and then lower down we have the bronchiole, we have the terminal bronchiole, we have the respiratory bronchiole, then we have the alveolar duct and alveolar, right? What are you supposed to remember in the bronchus is, here you can make out the bronchus here. Tracheaல வந்து hyaline cartilage ஒரு full stretchல பார்த்தோம்ல. Bronchusல வந்து you'll get to see plates of hyaline cartilage. Okay, they are broken down. Yeah, bronchiole என்ன இருக்கும் அப்படின்னு பார்த்தீங்கன்னா no cartilage. Here in the trachea, these are the seromucous glands that you see in the submucosa. Okay, so கீழ போக போக என்ன ஆகும்? Bronchiole, remember the no, there is no cartilage. There is no cartilage, there is no glands, no goblet cells. Okay, what is the new special type of cell that you get to see in the bronchiole? Any idea? The Clara cells. Okay, Clara cells. And the epithelium of the bronchiole will be changing to cuboidal, not the ciliated columnar. Cilia irukadu, columnar cells irukadu. You'll have the cuboidal cells. Okay. So these are the features that you see in the terminal bronchiole. I remember the Clara cell. Yeah, this was another image-based question once asked. What is the muscle pointed out? Excuse me. What is the muscle pointed out in this image here? You can see the vertebra, right? These are the lumbar vertebra. On either side of the lumbar vertebra, very good. That's the psoas major muscle, right? Like 2 years back, this question was asked, right? Or identify. And this is your hip bone. The muscle that here you see here will be the iliacus. Okay. Now remember that the psoas major is going to originate from the sides of the lumbar vertebra. And the fascia that's going to cover the psoas major will be psoas fascia. Lower down when it comes, they are going to be covered by the fascia iliaca. In the fascia iliaca, enna pannona, you know that, and remember that you have the lumbar plexus, right? Lumbar plexus is located within the psoas major muscle. Okay, lower down, this fascia iliaca, which comes down, it forms the posterior wall of the femoral sheath. Now, TB, tuberculosis of these vertebra, the abscess can track beneath the fascia. So if at all it comes to lie posterior to the femoral sheath and not of the front of femoral sheath. Okay. Yeah. So here, following the sciatic nerve, it can reach the gluteal region. And following inguinal region is the area of distribution of the iliohypogastric nerve. So it can follow the iliohypogastric nerve to reach the inguinal region, or it can follow the genitofemoral nerve to reach the inguinal canal. Okay. So psoas major by the side of the vertebra, and within the substance of the psoas major, the lumbar plexus is there. The psoas fascia is going to cover it. So any pus will be beneath the psoas fascia and track down along the course of the nerves. Okay, you can't see it in front of the femoral sheath. Erb's palsy, easy question, right? Yeah. So what were the options here? It occurs due to injury to the upper trunk. Erb's point, right? Axillary nerve is affected, yes or no? Yes. C5, C6 fibers are involved. This is going to supply the deltoid and the teres minor, right? So the patient will not be able to abduct. Which action is not possible? No abduction and no lateral rotation. That's why the arm is medially rotated and adducted and kept. Okay. And the supinators of the elbow are affected. What are the supinators of the elbow? The biceps, which is going to be innervated by the musculocutaneous nerve, and the supinator, which is going to be innervated by the radial nerve itself. Of course, this statement is also correct. Okay, so 2 is correct, 3 is correct. Nerve to serratus anterior is not involved. What is its root value? C5, C6, C7. Okay. Suprascapular nerve and nerve to subclavius, they emerge from the Erb's point. So that statement is correct. FDS and FDP is not involved. Okay, median nerve and ulnar nerve will be supplying it. Ulnar nerve is also not involved. Arm is medially rotated because the lateral rotators, the teres minor, infraspinators, all that will be paralyzed. Now tell me, what are the nerves involved in Erb's palsy? MANRS. Musculocutaneous nerve, axillary nerve, nerve to subclavius, radial nerve, and suprascapular nerve. Right? So, you know, Erb's palsy is easy, important. The question put can be in different format. You should be able to answer it. Right? We have done this in a rapid revision, so I'm not repeating it. Okay? Hope you got it right. Okay, here, yeah, as you told, it's lengthy, yeah, but it's easy, okay? So what are the things that are seen here? First point, laws of pain and temperature, where? Face and the left side of the body. Face ipsilateral, body contralateral. So what are the tracts involved here? Any sensation from the face, okay, where it is going? It's going to reach the spinal nucleus and tract of the fifth nerve. Body contralateral, that involves your spinothalamic tract, and pain and temperature. So it's going to be the lateral spinothalamic tract. Okay, done. Ataxia, intentional tremor. Okay, ataxia, that's all feature of the cerebellar peduncle or the inferior cerebellar peduncle as in this case. Okay, and then, yeah, hoarseness of voice. Nucleus ambiguous, again accompanied by paralysis of muscles of palate, pharynx, larynx. That's because of involvement of nucleus ambiguous. Okay. And then these are all features of Horner syndrome, right? Anhidrosis, ptosis, pupillary constriction due to involvement of the sympathetic fibers. Which one? Horner syndrome. Now, all these are placed where? Which one? The spinal nucleus of the trigeminal nerve, the lateral spinothalamic tract, the inferior cerebellar peduncle, the nucleus ambiguous, the sympathetic fibers are all placed over the posterolateral part of the medulla, which is going to be supplied by the postero-inferior cerebellar artery. Okay, so that's the lateral medullary syndrome or Wallenberg syndrome. That is okay. Now, whether it's right or left, as I told you, phase is ipsilateral. The only main thing contralateral is going to be the spinothalamic tract. So what is that? Loss of pain and temperature from the right side of the face. So the diagnosis clinching here, right? Posterior inferior cerebellar artery is involved. Wallenberg syndrome, right? Okay. This is again a different format they asked. Now I just want to tell you, highlight this word. Inability to dorsiflex, which means that this is another way of telling the patient has presented with foot drop, right? So every year, different format, they keep asking the same thing, neck of fibula fracture, which is going to be wound around by the common peroneal nerve. Okay, we have seen this. That's going to divide into superficial and deep. The deep peroneal nerve is going to supply the extensors or the dorsiflexors of the foot. That was an easy question, right? Yeah, so that was given as an image-based question also, pointing the neck of the fibula. Okay, recently they've asked that. Yeah. Yeah. True statement regarding Kugel's anastomotic artery. What is this Kugel's anastomotic artery? Yes, blood supply of heart is important and the variations also clinically important. So this Kugel's anastomotic artery, it's going to come from the left circumflex artery. Okay. Yeah, it is going to supply the left atrium, but it doesn't stop with it. Okay. It goes to the right atrium and anastomosis with a similar branch of the right coronary artery. Okay, so you can see it running along the interatrial septum and along the anterior atrial wall. So if you take it all, yeah, you'll get these ones right. From the left circumflux, okay, it is going to communicate with the right coronary artery, traverses interatrial septum, runs along the anterior atrial wall. Okay. So this is the diagram to show that this is your left circumflux and this is the Kugel's artery for the left atrium. Okay, blood supply of heart is important. You can't afford to skip any point from that. This is another frequently asked question, right? Yeah. Now you're going to tell me what is A, B, C, D. So A, this anterior part that you see here, anterior to the stomach will be the left anterior intraperitoneal recess, a part of your greater sac. What is B? Clinically important. Yes. What is this area that you see behind the stomach? Yeah. What do you call it? That's the lesser sac or the omental bursa. Another name, left posterior intraperitoneal recess. Anterior to the liver, that will be the right suprahepatic recess. Now, what is this D? This is the common site, right? Okay, for collection of your post-surgical, any pus fluid, it collects in this area, right? Behind the liver. What are its different names, right? It's called the right subhepatic recess. Yes, it is also called the right posterior, yeah, intraperitoneal recess. Yeah, I know it's called Morrison's pouch, but sometimes a different name is given. You shouldn't find difficult, right? It's called the hepatorenal pouch of Morrison, and it is also called the Morrison's pouch, right? One more important question here, I put another image, the epiploid foramen, right? This is the area of the epiploid foramen. What are the structures that you see in the anterior posterior relations of the epiploid foramen? So this is your lesser omentum. What do you get to see here? On the left side, right? This one is the, what is one? This is the hepatic artery, right? This is your hepatic artery. This one here, that's the common bile duct. This blue one here, that's the portal vein. All these three in the right pre-margin of the lesser omentum forming the anterior boundary of epiploid foramen and posteriorly inferior vena cava. What is the superior boundary for epiploid foramen? The caudate process of liver. Okay, the caudate process of liver. And inferiorly, it will be related to the superior surface of first part of duodenum. Now, what is the vertebral level of foramen of Winslow or the epiploid foramen? T12, right? Yes, all these are important related to that image. Yeah, so it is D. Yeah, this is easy, right? What is the answer? The answer is very good, right? Very good. So that's why I put a similar images, right? Yeah. Now, can you tell me what is this condition? This is dimpling of skin. Why does this occur in carcinoma breast? Due to involvement, due to infiltration of the malignant cells into ligament of Cooper or the suspensory ligament. Right? What is this you see here? This is retraction of nipple. Why does this occur? Due to infiltration of lactiferous ducts, right? Infiltration of the lactiferous duct. Because remember, the lactiferous duct are all going to open into the nipple, right? Yeah. Fixity of the breast tissue seen in, yeah, breast malignancy. What is it due to? Due to infiltration of malignant cells into the retromammary space, right? Retromammary space. What is this? Vertebral metastasis. Why does this occur or how does this occur? So the posterior aspect of the breast, the inner aspect is drained by posterior intercostal veins that opens in the azygos, which has communications with the bassins. Very good, Sai Krishna. Superb, okay? Yeah. So this is purely orange, blockage of the subcutaneous or the subdermal lymphatic blockage. Very good, okay? Yeah. So this one, easy. So what is there? The lesion involving the, yeah. Okay, at least you can tell me whether it's unilateral or bilateral, right? So it is a bilateral, okay? So both the part, I mean, right and the left half of the body is going to be involved, right? Now here, the important point is that this region, what is this region called? Connecting the right and the left half, the white part of that. It's called the white commissure, right? White commissure. This white commissure is an important point. And what tracts are going to cross here? The spinothalamic tract, okay? The lateral spinothalamic tract and the anterior spinothalamic tract, the fibers will cross here. So this lesion is actually syringomyelia. Cavity forms within the central canal that can extend anteriorly to involve the white commissure. It can also extend in different direction, okay? So it typically involves the spinothalamic tract. So there'll be bilateral loss of pain and temperature. Okay, mainly involves the cervical segments. Yeah, seen in syringomyelia, right? So generally you should know about the ascending tract and the descending tract. Of the ascending tract, which one is important? Posterior column. Recently, there was one question on it, right? So what are the sensations carried by the posterior column? Discriminative touch, right? 2-point discrimination, right? Stereognosis, vibration, proprioception. And remember, it's from the same side, ipsilateral, right? Fasciculus gracilis and cuneatus. Fasciculus gracilis from the lower part of the body, fasciculus cuneatus from the upper part of the body. Another ascending tract that you should definitely know will be the spinothalamic, as we saw now. What are the two spinothalamic tract? Anterior will carry touch, lateral will carry pain and temperature. Of the descending tract, the one that's very important is going to be the corticospinal tract, right? The pyramids. The spinothalamic tract, both are carrying fibers from the opposite side, so they'll be contralateral. Okay, now location of the fibers in these tracts, because recently the question was given, a knife is penetrating the dorsal part of the spinal column, only the lateral part of it. So this is the fasciculus gracilis and cuneatus. In the posterior column, the fibers that are more lateral will be cervical. So the knife would have penetrated only the cervical fibers. So the lesion would have been confined only to the upper limb. Cervical, thoracic, lumbar, and sacral. Okay, மத்த ரெண்டும் in the corticospinal spinothalamic tract the cervical is preserved. Okay, it is on the innermost, whereas the sacral fibers are on the periphery. Sacral, lumbar, thoracic, cervical. Here also outermost is the sacral, then you have the lumbar, thoracic, and cervical is innermost. So this is also important. Arrangement of fibers in the tract. And the spinal cord syndromes, the easier ones. So anterior 2/3 of the spinal cord is going to be supplied by anterior spinal artery. Its occlusion will again lead to features of that. And this one is the posterior 1/3 of the spinal cord is going to be supplied by posterior spinal artery. Both are going to come from vertebral artery. So this is called anterior cord syndrome. This is posterior cord syndrome. This is what we saw now in syringomyelia. Cavitating lesion involving the white commissure crossing of the fibers. Okay, you see the anterior gray horn is involved here, right? The lower motor neurons here. This is seen in poliomyelitis. And this typically posterior column, it is seen in syphilis, syphilitic degeneration, tabes dorsalis. So you should remember only the spinothalamic tract contralateral. Posterior column is going to be ipsilateral. Okay. Syringomyelia. This they keep asking again and again. The yellow arrow is at the neural crystals. Yes. So quickly, can we see what are the derivatives of the neural crystals? So you know what are the neural crystals, right? So if in case another part of the same image is asked, so this is the neural tube. Neural tube notochord. And this is your paraxial mesoderm. Either side, okay, the intraembryonic mesoderm. This paraxial mesoderm. This intermediate mesoderm. This is your intraembryonic coelom, which is going to form the pleural cavity, peritoneal cavity, pericardial cavity. So outer to that will be the somatopleuric layer of the lateral plate mesoderm. This will be splanchnopluric layer of the lateral plate mesoderm. Okay, so in the image important, idhula therira ellame important. They can ask you derivatives of anything. For example, notochordal derivatives in apical ligament of dens and nucleus pulposus. Right? Okay, so derivatives of neural crystals, the picture, you can remember this HCG. Okay, HCG is positive and poems are coming off. Now, what does the H stand for? We are talking about derivatives of neural crystals. Of that, H is for heart. Heart neural crystals ennalam kudukka pogudhu? Yes, conotruncal septum. And the endocardial cushions will give rise to the atrioventricular valves and semilunar valves. Right? Then C another. C is the cell. So that's why I put this poems. Okay. So what does POEMS stand for? P. P is for the parafollicular cells, the C cells of the thyroid gland. O for odontoblast. E for the enterochromaffin cells. M, there are 3 M's there. Adrenal medulla. Any other M you know? Melanoblast. One more, the leptomeninges. What are leptomeninges? Yes, the arachnoid and the pia mater. S is for the Schwann cells, satellite cells, all the neuroglial cells. G another, G is for the ganglia. So all the ganglia that you name it, okay, cranial nerve ganglia or the dorsal root ganglia or the sympathetic ganglia or the parasympathetic ganglia, even the parasympathetic ganglia that you see in the Meissner's Orbach's plexus. Everything is going to come from the neural crystals. Okay, a very important topic. Hope you're like it's at the tip of your fingers, right? Yeah, neural crystals. And then this one, recently they've asked about one ligament. That's why I put this question. Yes, did you get it right? What is the ligament here? It's given, right? Spring ligament. என்ன கேட்டிருக்காங்க எந்த ரெண்டு போனை கனெக்ட் பண்ணுது Sai Krishna, what did you write? Which was the answer? I'm sure you got it right, isn't it? Very good. Yeah, its other name is called the plantar calcaneonavicular ligament. Okay, plantar calcaneonavicular ligament. Yeah, so I put a picture here. Spring ligament is plantar calcaneonavicular ligament. Deltoid was the medial ligament of the knee. What is the Lisfranc ligament? What is Chopard ligament? So recently they have asked question about this Lisfranc ligament. Yeah, if you've seen the previous year question paper, you must have known by now, right? So idhula plantar, this is your calcaneum, talus, this is the naviculum, right? From the sustentaculum tali to the naviculum, this is the spring ligament. Okay, and there are 2 tendons related to it. The one which goes immediately below the sustentaculum tali here, the flexor hallucis longus tendon. Okay, this one, yeah, it's actually the flexor hallucis longus tendon. It goes below the sustentaculum tali. Innonu vandu tibialis posterior, that goes for insertion into the navicular tuberosity. 2 tendons that you should remember. And this is the deltoid ligament on the medial aspect of the knee. Aditha, what is this Lisfranc ligament? Did you go to the recent question papers? So the one which connects the medial cuneiform to the base of the second metatarsal. Okay, this one is the Lisfranc ligament, and tear of that they call it as Lisfranc fracture. Aditha, Chopard ligament another. Okay, you know this is the calcaneum, talus, naviculum, and cuboid, right? So from the calcaneum to the naviculum and cuboid, there is one bifurcate ligament. Okay, in the bifurcate ligament pair the Chopard's ligament. Okay, yes, so these are the important ligaments of the foot. Yeah, what is this? What is the cranial nerve involved here? So this is the right eye, this is the left eye. Left eye prominent features and you can see easily the drooping of the eyelid, ptosis. So injury to which cranial nerve will present with drooping? 3, 4, 6. Either. Third. Okay, I have given a mnemonic to remember the lesion of third nerve, right? What is this? So S stands for P for ptosis, E for external strabismus, D for dilated pupil. This is for apparent proptosis and loss of accommodation. These are the features of third cranial nerve palsy. We are talking about the third cranial nerve, right? So the third cranial nerve arises from the level of superior colliculus, right? Of course, it carries preganglionic parasympathetic fibers in the nucleus, Edinger-Westphal nucleus. Through which nerve does it branch? It pass through nerve to inferior oblique. What is the ganglia coming there? Ciliary ganglia. What is the postganglionic fibers called? Short ciliary nerves. that supplies the ciliaris and sphincter pupillae muscles, right? Which cranial nerve has the longest subarachnoid course? The fourth cranial nerve. Very good. Okay. Which nerve passes through the Doral's canal? Sixth cranial nerve. Right? What lies in the lateral wall of cavernous sinus? Of course, 3, 4, and 3 ophthalmic division, then the oculomotor and the trochlear. Does it innervate both the oblique muscles of the eyeball? Superior oblique innervate the fourth nerve. Inferior oblique is by the third cranial nerve. Of course, it supplies sphincter pupillae. Now, Sai Krishna, enna solla poringa? What is the nerve supply to the dilator pupillae? Dilator pupillae is going to be supplied by the sympathetics. Okay, please remember. Good. Yeah. So lower limb, they are always very much worried about the common peroneal nerve, superficial peroneal nerve, deep peroneal nerve. Why not if they ask for this nerve? What is this nerve? So, what is this nerve pointed out? In the region, this is the popliteal fossa, right? This is the region of the popliteal fossa. Cubital fossa matana kekanuma, popliteal fossa keta enna pandrathu. Upper angle of the popliteal fossa, the sciatic nerve. Sciatic nerve is going to divide into tibial nerve, which goes straight down. And this one, which goes slantingly, this is the common peroneal nerve. Common peroneal nerve, this is tibial nerve. Okay. Yeah, once they've asked the same question, but without an image. I just put an image here. So tibial nerve enna supply panna podu? It is going to supply all the muscles in the back of leg. And it will also give rise to the plantar nerves, the medial and lateral plantar nerves that supplies the sole of the foot, muscles in the sole of the foot. So, idhula edu tibial nerve supply pannalam? Sai solringla? Flexor digitorum longus, popliteus, soleus, gastrocnemius, all are going to be supplied by tibial nerve. Tibialis anterior supply pandrathu. It's a muscle in the anterior compartment of the leg. And the nerve of the anterior compartment of leg is deep peroneal nerve, which will cause dorsiflexion. Idoda injury will lead to foot drop. Another action of tibialis anterior is inversion, along with tibialis posterior. Okay, so much information is here. Popliteal fossa. Okay, other than tibial, now you get to see the other structures here. I will show you the popliteal artery here. This structure here, this is the popliteal artery. This one, this is the popliteal vein. Okay, sir? Yeah. This. So, yeah, you would have gone through the question, the case scenario questions pathona. Which of this is incorrect in Keterkanga? Superior mediastinum esophagus is present. Of course, it lies behind, posterior to trachea and arch of aorta. Left bronchus, it crosses anterior to the esophagus, but at what level? Yes, did you go through it? Of course, this was asked previously. Inferior thyroid artery supplies esophagus. Esophagus will pierce opposite to T10 vertebra. Right? The left bronchus will cross anterior to the esophagus at what vertebral level? Yes, sir. Do you remember? So this is the superior mediastinum, right? So you can see the esophagus here. This is the trachea here, right? What are the constrictions of the esophagus? Yeah, in the esophagus angle, this one, right? So at the first constriction, where is it? At the, yes, pharyngoesophageal junction, where the pharynx become esophagus, right? Second constriction enga irukudhu, that is crossed by the arch of aorta. Third constriction enga irukudhu, where it's crossed by the left bronchus. Last constriction enga irukudhu, where it pierces the diaphragm, right? Diaphragmatic opening la. Now, yes, this is C6, this is T10. Arch of aorta is T4, left bronchus is T6. And the distance of these constriction, yeah, from your incisor teeth, 3 times table, right? Yeah, 6, 9, idu mattum maru. Instead of 12, you're putting 11 and 15. Okay. So this is the distance of the constrictions from the incisor teeth, right? So all about esophagus, this is important. Yeah. This one, did you get it right, Sai? So what is the answer? Easy, right? So segmentectomy about the liver. Yeah. Now I'll put the option and show you a specimen of the liver. Idhila edu caudate lobe. Yes. What is A? What is B? Can you tell me? A is showing you the caudate lobe. B is showing the quadrate lobe. Right. Okay. Chill. Now, what are the boundaries of the caudate lobe? This one that you see here is yellow color. Okay. So this is the groove for inferior vena cava. To the right of it. Left another. This is the fissure for ligamentum venosum. Right? In the quadrate lobe, this you see the gallbladder, the fossa for the gallbladder. This is the fissure for ligamentum teres. Right? Okay, so from the image, you can get this all. So this is not wrong. Yeah. And sorry, wait. The caudate lobe is bounded. Yeah, so this is also going to be wrong, right? And the posterior surface of the caudate lobe, it lies opposite. Yeah, it opposite T10, T11, and T12. This is the region, right? This is the caudate process. So this will be forming the, yeah, what is that? Anterior boundary for the superior boundary for the epiploid foramen. Okay. Caudate lobe, yeah, it receives blood from left and right branches. Okay, now coming to the segments of the liver. This is turned, right? So yeah, you imagine the liver is like this. You have the falciform ligament, the Cantley's line, okay, that's going to divide, that will pass through the fossa for the gallbladder and the groove for IVC. So this will be the right half and this is going to be the left half of the liver. What is segment 1? 1 is caudate lobe, right? So the left half of the liver is going to be divided into medial and lateral, and right will be divided into anterior and posterior. So what are the segments? 1 is caudate lobe, 2 will be lateral superior, 3 will be lateral inferior, 4 will be the medial segment of the left lobe, and then we have 5, 6, 7, and 8. Okay, so segment 4A, 4 will belong to left hemiliver, right? Okay. This question is big, right? But it's easy. You must have read through the question. I'll just underline the point alone. Enna pannirukanga? Intramuscular injection, right deltoid la kuduthirukanga. Ennachu patient ku globular swelling. Okay, and what is the difficulty he's having? Movements are restricted. Could not abduct his arm. So, intramuscular injection enga kudukanum? Deltoid la dhaan kudukanum. What are the 2 nerves which are at risk of injury? Axillary nerve and the radial nerve in the spiral groove. So, inga enna sollitaanga? Not able to abduct. So, which nerve is involved? Axillary or radial nerve? Axillary nerve is going to supply deltoid, right? And that causes the 15 to 90 degree of abduction. So, abduction illa அப்படிங்கிறதுனால we have to clinch on to axillary nerve. If in case they have given the patient presented with wrist drop or inability to extend or dorsiflex his wrist, then we would have gone with radial nerve, right? So what are the things about the axillary nerve? We know the axillary nerve is also called the circumflex nerve. Okay, it has the root value C5, C6, and it comes from the posterior cord of the brachial plexus. So, humerusla எந்த part fracture ஆன axillary nerve involve ஆகும்? The surgical neck. It winds around the surgical neck of the posterior aspect of the surgical neck of humerus. It passes through the quadrangular space of axilla. Okay, it is going to supply 2 muscles, deltoidum, teres minorum. Deltoid வந்து 15 to 90 degree of abduction. teres minor is lateral rotation. இன்னொரு முக்கியமான point இருக்கு. It gives one cutaneous branch. Which one? Upper lateral cutaneous nerve of arm. Upper lateral cutaneous nerve of arm, axillary nerve oda branch na, then you should also know lower lateral cutaneous nerve of arm is a branch of radial nerve. Very good. Okay, in the cutaneous nerve poradnala da, yes, what is this called? Absence of sensation over that part. The regimental badge of anesthesia. Right? Yes. So we'll go on with this answer, right? Yeah. So this internal capsule is very, very important. You should know the parts of internal capsule. What are the fibers traversing the parts? What is the blood supply? What will happen in lesion? So inga enna kuduthirukanga, all the features are involving the face.
phone மட்டும்
ஆயிடுச்சா? ஏன் என்னோடது தெரிய மாட்டேங்குது வீடியோ? எப்படி லீவ் பண்றது? வீடியோ ஏன் தெரிய மாட்டேங்குது?
அது
1 second. You're able to see the video, sir? That's what I'm trying. Okay. Yeah, 1 sec. Sorry. Here. Video option photo in தெரிய மாட்டேங்குது. I'll just go out. I'll connect again and come. 1 second. I'll just leave and I'll get connect again. ஹலோ மேம். வீடியோ வர மாட்டேங்குது மேம். வந்துடுச்சு. இப்போ ஓகேயா மேம்?